Hi everyone, thank you for joining me. Allow me to introduce myself. My name is Georgie Gould and I'm the Project Assistant at Global Community Resourcing. I'm pleased to be the co-moderator for today's webinar and joined by Global Community Resourcing's Director of Projects and Research, Anne Livingston. Welcome, Anne.
Thank you, Georgie. The focus of today's webinar is extremely relevant with the times we're all having at the minute across the globe. The title today is COVID-19 and the delivery of smart care, the crisis, but also the aftermath. Our webinar today is facilitated by Global Community Resourcing for the Community Care Smart Assistive Technology Collaborative. As many of you be aware, we have extensive international linkages and have been fortunate to work on many international projects and with many research entities.
If you've joined us for previous webinars, you'll know that they are designed from feedback and requests we received through the collaborative. The focus of our webinar is to bring together local, national, and international perspectives in research and development, as well as development of smart assistive technology in the community care sector. Just a reminder that if you haven't formally registered at the collaborative site, it is accessible to all and free to register. Please note that Global Community Resourcing is not promoting or endorsing any particular product, research identity, or organisation. The purpose of our webinar is to serve and to inform viewers of various smart assistive technology collaborative currently in development or in deployment. We welcome questions, but I'll let you know that today's presentation has been pre-recorded. So if you have any further questions, please contact the collaborative research team via sat@communityresourcing.com.au. In this webinar, Dr. Kevin Doughty explores the sudden demand for smart technologies and virtual care services across the world, given the speed of the spread of COVID-19 has resulted in a little preparation time to improve supply chain and cease the resilience of service delivery. Dr. Doughty will explain many of the problems that have been solved by rapid innovation by attempting to try out new approaches. This webinar will address the many opportunities to improve progress to make service more efficient and effective. The presentation will consider 10 action areas and discuss the content of developing strategies for change.
Thanks, Georgie. Many of you would know Dr. Kevin Doughty from his previous work with the Community Care Smart Assistive Technology Collaborative. And Kevin's been involved in the collaborative since its inception, and I thank him for that involvement. Kevin, by trade, is a specialist researcher, advocate and consultant in smart technologies, systems and services. And he's done that for over 30 years, having previously set up and operated a residential care home for older people. Dr. Doughty is the visiting professor in digital transformation of care services at the University of Columbia and is the chairman of T-Cube Limited. T-Cube Limited is a specialist consultancy company focused on improving the deployment of smart assistive technologies and telehealth care services. He's also director of iCentre for Usable Home Technologies, which is leading a team of telecare service commissioners and providers across the UK in sharing best practice service evaluations and training developments. It's really a pleasure to welcome you back, Dr. Kevin Doughty, and I'll hand over controls to you now for your presentation. Thank you, Kevin.
Hello. I'm Kevin Doughty and pleased to be able to share with you some of my ideas and observations that have been apparent within the last 2 or 3 months as we take on board the impact of the COVID-19 crisis. The focus is, of course, on community care. So in a way, communities can support the more general healthcare systems by looking after people as they are discharged from hospital. As Anne said in the introduction, I'm looking at 10 possible areas of interest, and I'll discuss each quite briefly, but hopefully it'll bring out some of the action points that people either are considering already or have implemented for change. So to begin with, we look at this word telemedicine, which increasingly means the video side of this thing. And I think we have to look at where all the interactions may occur. Once upon a time, it really was a consultant to a consultant. Well, we now have genuine uh, interoperability between different teams. So the possibility of speaking to more than one person at a time is enabled through larger screens and better video systems. And so that's at the hospital level. And of course, if it's within the ITU or where someone is already isolated so that the staff are protected, then we can have machines doing that. But to remote sites, what happens in, for example, prisoners, people who might otherwise have not been the focus of care, people really don't want to have to go into these facilities. And at the same time, they really don't want to have to bring the prisoners out into a hospital because that might mean locking down A&D. What we've shown already is that it can reduce the admission, the need to transfer prisoners, and the relative cost is in UK terms £250 per appointment saved. So lockdowns are rather different in nature because we can now use high quality video consultation. Private consultations, once upon a time, 3 months ago, only 1% of UK consultations between patients and their GPs were via telephone or by video. Today, we now have a raft of new opportunities, and in fact, over half of the consultations are now occurring by telephone or video. And because it can be done by simple apps, the instructions are simple, and there's no longer the possibility of people saying, I can't do that because I'm not technology savvy. But it does make us think about what's the best way to introduce the technology to an older person. And by older, of course, age isn't a number. It's to do with people's ability or preferences in this term. So what if they have a problem with that video interface? Well, we're seeing innovations. We're seeing from Norway a device called a comp, one single knob for control, which takes away all the issues to do with multiple remote control units. But it is relatively expensive and it isn't that large. Whereas devices such as the GrandPad are designed very much for the older person in mind, but again, not that low cost. Alternatives mean using more generic equipment, the things that would not stigmatize someone because people have them in their homes already, or at least younger people do. Perhaps the best examples are the Amazon Echo series and the Google Hub, which have voice control already. They have cameras and they have video interfaces. So as a low cost intervention, these can work very well. My preference is actually to use one's own television, a typical 50-inch display these days, just a few $100s. And that gives you a camera that will track you around the room. And that's what I use during the lockdown to be able to communicate nightly, to have quiz nights. And it's something that older people can actually find very useful without the restriction of a small screen. So the second point is, how do we enhance the video content? It's all well and good telling the doctor what the symptoms might be, but unless the doctor can check them himself or herself, then that doesn't give him all the tools available. So we're seeing a number of products, low-cost products. Yes, the quality of the medical interface may not be perfect, but it's ideal for a triage. And one of the first was called MedWand, and it was designed for children in particular. So the parents actually use the device. Then the remote doctor looks at the results and comes up with a diagnosis or decides what should be done. The alternative, which is more recently available, is from Taito. Perhaps Taito is more familiar as a manufacturer of high quality toys, but their product actually is high quality. It does everything from looking at the inside the ears. It allows looking down the throat, takes measurements of breathing, heart rate, and all for under American dollars 300. So that's perhaps £200 sterling or 400 Australian dollars. Quite a bargain, I suspect. But for longer term, there are wearable devices, and there's a whole raft of these. You can put a device absolutely anywhere. So whether you're diabetic or whether you have a heart problem, or whether you simply want to track performance, these are low cost and readily available through their appropriate app. The third point I want to look at is the need for autonomous delivery vehicles. Some of them will be things that can roll around the streets. Of course, they're modified pizza delivery vehicles, if you like. But because they can go along the pavements without bumping into people and infecting them, then they could have lots of uses for not only drug delivery, but also for basic needs of food and drink. Drones will do similar things, and in Australia, of course, you have experience on some of the islands on how to deliver things quickly. Let's not forget, although, firstly, the need to access homes in some places. So there may be need for key safes, but also there are a lot of people who are still going out and about. They may be delivering the mail, they may be reading meters, they may be actually delivering milk even. They can be repurposed specifically to look for people who are in trouble and who might need interaction. One of the challenges that hospitals have is how do they empty their beds quickly to enable them to be filled up with people who have emergency needs because of COVID. It's how do you secure discharge whilst attending to firstly their medication needs or their monitoring of their medical needs. And that means using devices that could be strapped on. The diagram I'm showing there, that has been used in London hospitals. It's a medical grade monitor. So it provides blood pressure, a pulse oximetry, and all the other relevant factors at a level which is actually ICU grade, not simply hospital grade. And then there are other devices which are going to be wireless and link with an app, which enables someone to be monitored from their home. Secondly, we might look at how they're performing there. There's no point sending someone home if they then decline because they're unable to compete and complete the activities of daily living. We have Internet of Things systems which allow dashboards to be produced so we can have red lights when people's condition is deteriorating, which leads to interventions. Thirdly, we have the possibility of using smart assistive technologies, and these could be used in lots of roles. So perhaps that's worth spending a little more time on. We know there are 4 different groups. These can be labeled as fixed devices, which really are modifications to the home, very small devices you take with you, perhaps the more complex devices, and then the connected devices. And these could be split in various ways, whether it's mechanical and electronic, but perhaps more relevant today is the splitting between those that are quick and easy to provide, which enable people to go home quickly, and those that might take a little longer. Well, those on the right are absolutely ideal for hospital discharge because they can provide it there and then, or can be provided quickly when a single assessor appears in that home. And then the others, well, some of them can be standard because they're minor adaptations and they can be provided quickly as well. So it provides a new focus on that range of smart assistive technologies. So who knows what everyone needs? It does require better practical assessment, training, which is difficult to do. It takes a long time, perhaps. But really, the 4 or 5 key things are, firstly, that we have to know the person and then their circumstances. We need all the technologies to be understood, knowing which works, when they work, and whether it's appropriate. And then to put it in a service so that because it's no longer simply a hardware product that's bought and provided one-off. It's now a service as well. And that sort of change is perhaps difficult to implement, especially when you can't have joint visits and you can't refer on to another service, because in days of lockdown, when you want the minimum number of outside people coming into the home, that one person needs to be able to do all the assessments. They need to assess the risks. They need to look at what isn't there, what the person's needs are. They also need to look at increasingly their telecommunications. Do they have broadband? Do they have a good mobile phone connection? And then they have to rely on their own knowledge and what they see to determine those concerns and the issues that are perhaps evident on their weaknesses somewhere. So those concerns are the key. And one way that we've been doing it is by giving people examples. We call them vignettes. Lots of different people, if you like. We introduce them for training purposes. And that says, okay, we can show people inside people's homes. Increasingly, they'll be based on virtual reality headset, give people the experience of doing that. Let them decide what the concerns might be. And there's a whole raft of these. And the concerns themselves are all associated with different solutions. So ultimately, this is what needs to be provided. And again, they look at all types of solution, whether it's changing someone's monitoring requirements or providing them with better facilities. So that's what's going on, and that needs, I think, an app, but more generally, it's going to need training. And for innovation, we need to, sometimes people simply cannot go home because of where they live. It's not accessible, and the property may not have an elevator. They may not be able to get upstairs. So what do you do? Well, what we're seeing is hotels which have emptied because of the crisis, they are now being used as step-down care facilities. In London, UCL, they used to use a local hotel as a step down unit many years ago. It was only over the road from the hospital. Now we're seeing big chains offering their facilities, and they do have good internet access. They all have ensuite facilities, and I can see hotels in holiday resorts, for example, adding some basic telecare features to give some confidence to their users and give them connection to their care providers. Replacement staff, well, do we really need well-trained staff in all situations? So in Devon, for example, they're using the local vets to provide support in their ICU facility. Hampshire, they have a new bedside support role. So I think the opportunity of redeployment, when you shut down many other community services, what do you use your speech and language therapists for? What do you use your occupational therapists for? Well, they are clearly healthcare workers. They have experience, expertise. They can be on the front line, and they can take on roles that previously would not have been considered. Other levels of innovation, there will be robots, of course. We know that very bright, very intense ultraviolet light can provide a disinfectant effect. It will kill bugs and viruses, but the level would be such that it would cause burns of the skin. It could cause skin cancer, indeed, if humans went in there trying to do this. So ideal opportunities for robotic assistance at a more general level. And then we have social robots who can become companions. And there is a large range of these, all with different names, communicating, speaking, providing links, providing a screen very often. Some of them will roll around, follow the person around. And we know some of them are designed specifically to learn experiences and therefore to have interactions with the individual they're providing support for. Social prescribing is something which has been available in the UK for the last 4 or 5 years. And it's a rather different prescription that's a GP and other healthcare professionals can recommend. And it's based on volunteering. And when it's not simply having a healthcare solution, Perhaps it replaces drug therapies. Perhaps it replaces some of the cognitive behavioral therapies. But what it does do is focus on the charity sector, the third sector, and offer people those elements that are higher up the Maslow hierarchy and which can help people's quality of life improve. So the idea is that there would be a support worker who would recommend and then prescribe to someone, perhaps an arts and crafts class, or joining of a choir, or the participation in some form of sport. And why is that relevant? Well, I personally see a lighter touch approach. And if you think of the assessment once again and what people actually need to have, the old approach, the traditional one, if you like, was all about places. So places and people. So you sent people into residential care or daily into a care centre or to a rehabilitation centre, and you provided them with people who might support them or perform tasks with them or for them. All these are very expensive, and at the current time, they are actually not possible because there's a restriction on movement and on people's movement into these centres. But perhaps the underlying problem is one of cost and support. So the alternative, these lighter touch ones, use our smart technologies. They use telecare, perhaps more dependence on friends and families, these social prescriptions, yes. Apps, people using their own devices, digital therapeutics. So can we do it without having perhaps the workshop facilities that once would have been used? And can we use community equipment, whether it's a crutch or a walking frame or something like an exoskeleton, something far more intelligent to replace that? And the whole idea, of course, that the cost decreases as we move from the old approach to the light touch approach. But at these times, it's not only the cost, but the access that changes. So how many of these go through a centre of some sort? Well, my model up to the last couple of years is about this super centre, a monitoring and support centre. Maybe a country like Australia might need 4 or 5. The UK might need only 20 when we currently have nearly 300. I can't see how they would do this in a world where they need to provide single points of access. They need to provide the video triage. They need to change from alarms into alerts. And only then can they provide facilities, checking things, and use artificial intelligence to provide all these range of facilities and applications. They'll exchange information as well. And they'll have live video feeds, whether it's inside people's homes or whether it's inside a community support centre. So that was my model 2 years ago, but increasingly it requires a very big centre and it doesn't allow that local coordination that perhaps people need. So perhaps a new model would be to make use of the internet and the World Wide Web. So the individual in their home is communicating with that cloud in some way. And on one side of them, yes, they have that alarm center and all the immediate response services who would come to their rescue if there was something wrong. But equally to the other side, there's a community coordination center, the people who would look at the volunteers and those who might come next day rather than immediately. So in the future, will it be one big center that does all of that, or will it be a hub and spoke? I think we'll see lots of different models emerging. Some of them will be 24 hours. Obviously, the alarm center would be, but I would imagine the community support centers might work perhaps 8 in the morning till 8 at night. We are moving into a digital changeover. Everything has been accelerated, but the plan has always been there. We're going away from the old analog communication systems, the old, what we call the old POTS system for telephone, and we're moving to a digital system where it's all IP based. And in many European countries, there's a target of 5 years for this transformation. So that means moving away from those old products on the left to a new range of products and a new set of products with new applications. And of course, a migration is needed, there's a cost, and organizations actually aren't ready to migrate, and they'll need to be, and they'll need to have a plan. I think all of that will be accelerated as we rise from perhaps the ashes of the old systems. I think we'll move very quickly into digital systems, giving us always on connections, opportunities to move up again the pyramid from detection right through to prevention. The problem with digital transformation is really one of speed, and speed for the developers. We've been in a situation, we've had this curve of the emergence of telecare and smart technology. Perhaps 50 years ago, it grew, it matured, and now we are in a state of decline because nobody anymore talks about smart hubs when you have complete smart homes. The digital world is taking over. We have IP telephony, more and more smart home integration, and all the clever stuff of data analytics and artificial intelligence and our social robots. The problem we have is that there's a gap there, a transition, and we're right in the middle of that transition, and I think it will accelerate. But what the problem for the companies is going to be that the half-life of a product before it's replaced by something bigger and better is less than 2 years, which means that they must get to market very quickly. They must have a means of engaging with their customers or with their commissioners, whether they're payers or providers, and then move in quickly so that they can transition people. People keep their smartphones only on average 2 or perhaps 3 years. That's the size of a contract. That's the world of the digital transforms services. Virtual wards are really to do with how do we empty those hospitals? How do we avoid the situation where they're all clogged up because people can't go home, because they need specialist equipment, smart assistive technologies. They need carers to learn how to use new equipment. They might need 2 at a time to help them because of their weight or frailty. They need to be monitored actively and online, and they may need rehabilitation as well to overcome the problem that took them into hospital in the first place. And I should add, they'll also need mental rehabilitation, because the effect of being in an intensive care ward for 2 or 3 weeks can take months and months. It's the equivalent of a battlefield scenario. So we do need to look again at our assistive technology approaches. We need to look at what sort of beds we've got that can help us get out without help. And we also need to move forward then on what's going to be that provision halfway house. We could use chalets, we could use holiday parks. And in Wales, the Pembrokeshire's biggest holiday park, that's been repurposed to take people moving between hospital and home. But they're no use unless they're fitted with the right equipment. They need to receive the therapy when available. They need to relearn those activities of daily living, and they still need the alarm services in there. Tools for the trade, we'll see far more digital systems, and one particular one that I like is the idea of using virtual reality for stroke survivors by strapping the devices on the individual. They don't actually need to perform really complex tasks that might have required a workshop. They can now do it online and therefore at home. And finally, what do we do for ourselves? It's all about self-care, self-management, a do-it-yourself approach to care, because that's the only affordable one that improves self-esteem and puts us at the center of provision. Well, self-care needs to look at all these different domains. And it's a lot of things that we have to buy for ourselves or use our existing equipment, perhaps in conjunction with an app or two. So I see a big role for buy or use your own devices and technology. We're already doing it. If you go into any pharmacy, you'll see there are consumer health product groups there, of which the ones that are perhaps most important are that small group there relating to test devices and equipment. And that's includes people's devices they already have, which is a smartphone, a tablet, all these devices that we now expect to buy for ourselves, whether for games purposes or for others. And a range of these do work with apps. And so apps may be the frontier of the self-care of tomorrow. So make sure we've got enough apps, make sure they're professionally validated, make sure they do what people want. Right, well, thank you for your attention. As always, information will be available through community resourcing worldwide and or direct contact with me. Thank you.
Thank you, Kevin. Great presentation today. We're going to go to some questions now, and I have been inundated with questions. So I'm going to start with the questions now, Kevin. Just a comment from Frank. I love your common sense 10-point plan for introducing technology to older people and people with disabilities. Thanks, Kevin, for your presentation.
Thank you.
So I reflect also on a previous webinar that we held with our colleague, Dr. Sabrina Pitt, from the, she's got an interest in rural and remote health and care delivery. And Sabrina talks about forced innovation. I guess we've got a number of questions that have come in prior to your presentation, Kevin, about do you think the digital transformation that we're experiencing because we're forced to is going to last? And if it's going to last, what are some of your strategies for our workforce?
I do think the forced innovation will cause change that doesn't really have a return button. We can't go backwards. We will throw away many of the old analog systems. They will be condemned to the museum. And I think you're right in identifying the challenge of the workforce. Many of the people in the workforce, perhaps providing the key frontline services, are approaching the ends of their career, although some of them think that when they're in their 50s, when I think part of the digital transformation will mean people working until they're into their 70s. And that really requires a new level of confidence. And the training, therefore, is very different. It's all well and good putting on courses where people can attend, learn something once, but unless they then actually use it over and over again, it really is a case of use it or lose it. And that's why I think we need a wide range of opportunities of engaging them. And I mentioned the Vivo toolkit approach. That really is for teams, and it engages teams in the ethics, and they actually come up with rather different solutions to the ones which others might have thought of were the best practice. And this is where the mix and match, where you can get people's experience built in there. And that's how teams learn. And of course, when individuals go out, they need online support. So I think we will have that mixed approach to empower people to really take on the digital transformation themselves. And I think we'll see people who might previously have been considered Luddites certainly seeing the light and moving forward. But I think we've got a lot of hard work to do to engage that group and to ensure that they don't drop out, because we will need everyone if we're going to get through this crisis.
So thanks, Kevin. Digital inclusion is the important component, isn't it? And making sure that any group that's digitally excluded actually has an opportunity to be included at this very important time. I guess a number of projects we've been working on for the last 10 years have really concentrated on the issue of digital inclusion, not only for the client base, but the workforce. And we're seeing more and more that the workforce within community-based care are people who haven't had the opportunity to really be upgraded and skilled. Do you have any comments about how you can most effectively do that?
Yes, I'm in exactly that position now where I see the workforce themselves wanting to engage, and they, in a way, become a mouthpiece, I believe, for the clients that they deal with. Many who don't see the relevance of the digital agenda and therefore don't engage and buy into a broadband system, don't have a tool that they can use. And yet, during this knockdown, this crisis, we see people being provided short term with mobile broadband systems. They are loaned iPads. They certainly realize that their smart TVs have functions that actually can be used to download films or whatever. So once everyone is engaged in that, they are now asking the questions. So in my experience, the workforce are being asked by the clients, how do they get online? So the workforce are having to test out things for themselves, whether it's giving them an opinion on the comparison between Skype and Zoom or Microsoft Teams or any of the other interfaces. And I think they now realize that part of almost a domiciliary carer role is actually helping overcome the little problems that we tend to overlook. You know, we have our routers crash on us occasionally. We know that it's switch it off and reboot it and it works. That's a disaster for someone lacking in confidence. And those are things that the people who do deal with them every day need to give them that confidence that it really isn't a big deal. You can't kill anyone by playing around with your system. You can't break it that easily. So I think the confidence factor will go from the ground upwards. We've seen amazing changes in the use of apps and smartphones. The domiciliary care industry is now based on people having smartphones and engaging with their employers, having quick means of communication. It leads naturally. It does take time, but I do believe that the silver lining for COVID-19 has been that digital transformation. And it has started with the experts, the care providers themselves learning how to do it. And that's working from home, something once upon a time was perhaps only to the very well educated who could afford to stay at home. It's now everyone's business, and it's happening easily and to everyone.
So Kevin, remote working, I guess for many of us working in specialised areas and in projects that span the globe, has been a reality. And it's interesting the amount of comments that our team has had about how we're managing through this time. We've always managed through remote working, and sharing those experiences about what works in remote working is certainly something you and I have done, and
Yes.
many of our colleagues have done across the globe. And I think that we perhaps should do another session on remote working. I've got one final question to ask, and I've got a lot of questions here, so I'm just trying to amalgamate some of them. Your question about call centres. You know, we've had an era of call centres, and we've had an era of the appropriateness of call centres operating 24 hours a day across countries, across different nations. It appears to me that, and some of our questioners, that there are some great opportunities to transform some of the workforces that have diminished over this crisis. Those that focused on customer service, perhaps in hospitality or travel, to rethink that whole notion of remote support for vulnerable people. Do you want to comment on that?
Yes, indeed. I really do see a different, almost a hierarchy of call center, where it's no longer about the emergency. That really is at the top, but you've got to define it. But all the way down, there'll be people who will be prepared to spend time and share experiences. It's the equivalent of the charity workers having a chat to someone lonely. Well, these days, you can play games online, you can do puzzles online. And I think it is the video element that actually has the greatest transforming effect. I think the chatbots are possible, of course, when it comes to answering a question. So no longer will people ask the question simply to get the opening. I think people will be more specific, that they want to see who they're speaking with, and therefore they get a more honest answer. And the person at the other end, of course, can go on board and use all the multimedia available to them to share an experience. And it goes as simple as, I mean, I suppose I should say that my favorite question to someone from a call center who phones me is, what's the weather like today? Okay, maybe it's a very British question, which if you're in the heat of India, it may be a strange question to ask, but it's always the way to engage people. And I see that as being the much wider conversation about experiences. And I think it will work for people who have cognitive impairments as well. But certainly those who are lonely, who want to get out, you can have the virtual outness. And it means having more cameras. And I think we will have cameras that were once used perhaps for surveillance, are now used for entertainment. I'd love to see cameras on the seashore looking at good views that people like to have. You should be able to switch between them. And that could be a role that's facilitated by a call center. So really it's more than simply providing advice. It's actually providing a service which can be charged for, of course. Great new opportunities, and I think we have to think globally in this way.
Thanks, Kevin. We've certainly listened and learnt from you globally about the experiences. I really thank you for your input today. Some of our terminology might be different. I'm not quite sure how many chalets we have in Australia, but I'm going to look that up. But a lot of our experiences are the same. The use of resources that might have been motels and hotels for tourism are now becoming our isolation facilities and step-down care facilities. So we've got lots of things in common, but lots of lessons to learn from each other. I'm going to hand over to my colleague, Georgie Gilt, who's going to close today's session. Thanks, Georgie.
Thanks, Anne, and thank you, Kevin, for your presentation. If you haven't already done so, please go online and register for the collaborative. You will be able to access today's presentation and have the opportunity to ask further questions. Please check the collaborative for more information on our upcoming events and webinars. If you have any further questions or inquiries, email us at sat@communityresourcing.com.au, the email address that is on your screen now. I'd like to thank the members of the collaborative research team, today's guest speaker, Dr. Kevin Doughty, and my co-moderator, Anne Livingston.